This is Heart Rhythm TV, and I'm Daniel Alyesh here at the European Heart Rhythm Association Congress, fresh off of the CE Mark study for the Volt clinical trial. And I'm joined today by Dr. Roland Tilz, the presenting author for that study. Welcome.
Hello.
So big news in the world of PFA, especially in the context of having another option available. Now, this is a pretty unique catheter design.
Yes.
And so I'll briefly summarize your trial. 146 patients treated at 20 centers with both paroxysmal and persistent inflows. Tell us about your primary outcomes and your findings.
Yeah. Number one, all but one single vein could be isolated with the balloon. Number two, we only needed a mean of 4 applications per vein to isolate the pulmonary veins. It was a minimum of 2 per protocol and an average of 4. Number three, the adverse event rate was 2.7%. So 1 patient had a cardiac tamponade, 2 patients had a vascular access complication, and 1 patient was readmitted a couple of days after the procedure with a pneumonia, which was not procedure related. None of the adverse event was related to the Volt balloon. During 6 months follow-up, 86% of the patients with paroxysmal AF and 72% of the patients with persistent AF remained in sinus rhythm and free of any other interventions, such as escalation of antiarrhythmic drug therapy. In addition, more than 1 out of 3 patients was not treated with GA, but with deep or conscious sedation. And interestingly, those patients required less PFA application as compared to the patients in GA, which is indicating that you have only minimum diaphragm contraction, muscle contraction, and it's still safe to perform the procedure without GA.
I actually wanted to dive into your final point there because I didn't realize that. So we were part of the American version of this, and so there are 2 protocols, right, for delivery. There's
Yes.
the low and the nominal,
Yes.
right? And the low potentially gives it the option for conscious sedation. Is that right?
No, both are
Both
suitable
do.
for conscious sedation. So the high means 1,800 volt,
Yeah.
and the lower one is 1,400. And this is only depending on phrenic nerve capture. So we typically, before application of the right-sided veins, we would case each electrode. And if we capture the phrenic nerve, we would use the low protocol, and we would deliver less energy, but 3 applications instead of 2 applications.
So this is a bipolar
Yes.
bipolar delivery.
Yes.
So you're saying there's not a lot of skeletal muscle recruitment with
Yes,
that
yes.
algorithm, which is really wonderful for people who are trying to push the envelope back to conscious sedation. So that's
Yes.
a very interesting finding.
Yes.
The other question I had for you, so excellent 6-month efficacy. Can you project forward to say, what would your guess be for at a year, these outcomes? Would you project they'd be similar, or I know I'm asking you to predict the future, but that's not
No.
sure.
I mean, in terms of the outcome, I mean, this is why I think from a regulation perspective, you don't need 12 months follow-up because you can project the outcome after 12 months. Most of the recurrences you have within the first 6 months. So you have another maybe like 5% a higher recurrence rate if you add another 6 months.
Absolutely. Now, you talked about 4 applications
Yes.
per vein. So on
Yes.
average, we're doing about 16 applications.
17 to be precise.
Yeah, 17 per procedure. Now, I know that you can't compare all the recipes or algorithms
Yes.
across PFA platforms, but, in the case of PFA, the right amount is the right amount, and there can
Yes.
be too much. And so we always are concerned about things like hemolysis.
Yes.
So you report, or you have some understanding of the risk of hemolysis with regards to the Volt catheter. So I'd ask you to elaborate on that.
Yeah, I mean, it's not only about the total number of applications. The Volt balloon is also a balloon, which means it's a balloon in basket. This means that it's an insulation. And then the electrodes, you push the electrodes into the tissue, and you don't have electrodes floating the blood pool. So this means the energy transmission into the tissue is more efficient. And you have less energy transmission into the blood pool, which results in less hemolysis and bigger lesion formation.
Having had some experience with the catheter, I can say that it does feel very powerful because the energy is directed into the tissue, like you said, and away from the blood pool. So finding lower risk of acute kidney injury related to hemolysis and none in your study, correct?
Yes.
Yeah.
What is also significant, I think, underlines the power of the tool is 6 out of all patients had a redo procedure after the blanking period with left atrial redo procedures, and all but a single vein were isolated. So it has a very high durable PV isolation rate,
Okay.
despite the fact that we only used so few applications.
So the catheter design enhances the safety. It also improves the energy delivery. But the other unique thing about this, relative to maybe some of the other platforms available, is that it is also fully integrated in a magnetic mapping system. Comment a little bit about your experience using the system in that way.
Yeah, actually, within the study, we had to do a pre-map and post-map using the HG Quick Map. Since the study is completed, we started to do the map with the volt balloon. So you can do a beautiful map and a voltage map, collect the geometry just with the volt balloon. It takes just a couple of minutes. And I think this might be, or this will be the future in Europe. So I think we're not going to add an additional catheter. We just create the geometry with the volt balloon, which is very fast because of the large size of the balloon. And it is very important to better understand the anatomy and also to better understand whether you have a good balloon to tissue contact. As an additional tool, you have an impedance-based assessment of the balloon to tissue contact, which is also very valuable.
We know that contact is important for PFA durability, and maybe even a little bit of contact force. So yes, the impedance-based parameter to understand whether you're in contact can be very helpful. So I'm going to ask you a few questions about different practice patterns here in Europe versus the United States. Okay. So my understanding, so 100% of cases, or near 100% of cases in the U.S. have a map.
Yes.
At least pre. It's my feeling that a patient deserves a map to understand the substrate before you ablate it. 100% or nearly 100% are also getting ICE in the United States. Now, 15 to 20% is my understanding in Europe are currently using mapping for PFA ablation of AFib. Will the Volt change that?
For sure. It's so easy and fast to collect a 3D anatomy and to create an electroanatomical map and understand whether the patient is substrate or not substrate. It's not a high resolution map with the HG, but that's not what you need. You need to understand, does he have substrate, low voltage? You need to understand the geometry. You need to understand the anatomy of the vein. So where is it located? How big is it? And this you can perfectly create within a few minutes with the Volt balloon.
It's always interesting to learn different practice patterns because what we feel we do is right, but at the same time we can learn from each other. Well, thank you for this valuable contribution to the literature. Congratulations.
Thank you so much for the wonderful conversation, and we're looking forward to gain even more experience with this fascinating technology.
And thank you all for tuning in to Heart Rhythm TV.